Thank you very much. It's great to be here, and I'd like to thank CHP very much for the invitation to come over to Australia to address this conference, which I'm really looking forward to participating in over the next 2 days. I was asked to speak this morning about some research that we've done in the United Kingdom, which has been looking at what we have termed in the UK multiple exclusion homelessness. So I just want you to bear in mind as I speak that the focus of this particular study that I'm talking about, there's plenty of other studies that are a bit different, but this particular study has a much narrower focus than the work that Rosanna was talking about, which was looking at homelessness very much in the broad sweep. This multiple exclusion homelessness research was looking at people who were experiencing homelessness in combination with other forms of sort of complex issues specifically. It was part of a broader research programme funded by our National Economic and Social Research Council into multiple exclusion homelessness. Most of the studies were qualitative in nature, but this particular one, which I was leading on, was a quantitative study of the nature and patterns of multiple exclusion homelessness in the UK. Now, in the UK and actually elsewhere in Europe, most of our research on homelessness tends to be qualitative in nature, and which has left something of a gap in terms of robust statistical work on actually most forms of homelessness, but particularly on people at the more kind of extreme chronic end of homelessness, and that's what we were hoping to help to fill the gap in that with this study. It was a multi-stage survey of people experiencing multiple exclusion homelessness, and I will give you the definition of that in a second. The more extreme end of homelessness in 7 UK cities. I won't go through them, but the key point to make is that these cities were selected on the basis that existing information such as there was suggested that these were the major urban areas with the largest concentrations of people experiencing the more extreme forms of homelessness. As with Rosanna's research, there's a large team of us involved in the study. I was leading it, but there were colleagues in research companies, and actually a number of universities, and also we worked with 39 voluntary sector organisations to help us deliver the research. So it was a very big team effort. What do we mean when we use the term multiple exclusion homelessness? How we defined it in this study, and we did need quite a tight definition given that it was a statistical study, it was people were defined as having experienced MEH, if I can call it that from now on, if they had experienced homelessness, broadly defined, not just rough sleeping, but also other forms of temporary and very marginal forms of accommodation. If they had experienced homelessness and at least one of the others, they had been in institutional care of some kind, prison, local authority care or mental health institutions. They've experienced substance misuse, drugs, alcohol or solvents and gas abuse. Or they have been involved in what we call street culture activities. And by that what we mean is activities such as begging, street drinking and engagement in survival forms of economic activity like street-based sex work and shoplifting. So when I talk about MEH for the remainder of the presentation, what I'm talking about is people who've experienced both homelessness and at least one of the others, not necessarily all of them, but at least one of the others. Because we were looking at that interface between homelessness and other extreme forms of exclusion. Say something briefly about the methods. I want to get on to the findings, but we do have to explain a little bit about what it is we've done for people to get a sense of what I'm basing the findings on. Because it was a quantitative study, we needed a statistically representative sample, and that's really very challenging when you are trying to do research on a very excluded group. So that's why we had a 3-stage process in all of the cities that we studied. First of all, we, with the help of our voluntary sector partners, came up with a list of all of the relevant low-threshold service agencies in each city. What we mean by low-threshold are the kind of agencies which make few demands on their service users. So it would be services like drop-in facilities, day centres, street outreach work and so on. The kind of services where you don't have to sign up to certain forms of behavioural change or plans for going forward. You can simply sort of turn up or be there and accept the service. The idea being that some people who might not be willing to engage with more structured services would perhaps still be in contact with these lower threshold services. I emphasise the word relevant as well, because I think one of the most important parts of our research design is these agencies, these low threshold agencies, were not simply homelessness agencies. We also surveyed drugs agencies, criminal justice agencies, agencies working with people involved in street prostitution and so on. So we're looking at the interface between homelessness and these other forms of deep exclusion. Once we got the full list, and we made this list as extensive as possible of all of the agencies that were relevant in each city, we then randomly sampled 6 of the agencies to focus the study on. And the first major part of the field work, and the most risky part of the field work, was what we call the census questionnaire survey of all of the service users and all of these agencies over a 2-week time window. We wanted to get as broad a sweep of people's experiences as possible. We asked a very straightforward 14-question yes/no paper questionnaire type. Took that sort of approach in this initial stage. So we asked very straightforward questions about whether people had ever begged, had ever slept rough, had ever taken hard drugs, and so on. We got 1,300 questionnaires returned, which we were very pleased about. And we used that as a basis then for the main stage of the fieldwork, which was the extended interviews with a sample of the service users whose census responses indicated that they had experienced MEH. We interviewed 452 people in depth for about an hour. So by the UK standards, this was a very large sample, and it was certainly big enough to do statistical research on, which we were very pleased about. So I'm going to say something about the findings from both stages of the research. The census stage, because that enabled us to answer certain research questions, and the extended interview stage, because that enabled us to answer other interesting research questions. Start with the census survey results, and bear in mind that these are the results based on a questionnaire survey of all of the users of all of these services, not just homelessness services, but people using drug services, criminal justice, sex work services, and so on. The first thing that we found was that there was a very high degree of overlap between 4 domains of deep social exclusion that we were interested in. Now, we expected there to be overlap, that was those intersections that we were interested in, but we didn't expect the overlap to be quite this high. And this Venn diagram has quite an impact on policy and practice in the UK, because what it shows is the extensive nature of the overlap between institutional care, homelessness, substance misuse and street culture activities across people using all this whole range of services. So bear in mind it's not just homelessness services, but look at the percentage on homelessness, just how ubiquitous homelessness is. 98% of all of these service users had been homeless at some point. Many of them were homeless at the point that we interviewed them. But also engagement in street culture activities, institutional care and substance misuse was also extremely high. And in the middle there you've got almost half of the sample, almost half of those 1,300 people nearly had experienced all 4. So they had been homeless, they'd been in institutional care, they had experienced substance misuse, and they had been engaged in street culture activities. Let's go back to another couple of points I wanted to make, which are related to that Venn diagram. Second bullet point there makes the point about how prevalent homelessness is. Now, you might say, well, there's a lot of homelessness services in your sample, so you'd expect homelessness to be prevalent. But one of the most striking findings for us is that people who we sampled through drugs agencies in particular were just as likely to have experienced homelessness as the people we sampled through the homelessness services. They were somewhat less likely to have slept rough, but 70% of people that we sampled through the drugs agencies had also slept rough, and in fact they were more likely than people sampled through the homelessness agencies to have experienced certain other forms of homelessness, like staying temporarily with friends and relatives, or living in temporary accommodation like hostels. The other key finding from the census stage of the study was that Westminster and London looked very different from the other 6 cities. The other 6 cities, the 6 provincial cities, all looked almost exactly the same. Belfast and Glasgow, Cardiff, Bristol, they all look very, very similar to each other in terms of the patterns of experiences that people reported. Westminster and London was the only one that looked different. And we've written a whole paper on this, but the headline point is that the main reason why Westminster and London looked so different, and it looked different in the sense that people generally reported a lower level of complexity. They were less likely to report the whole range of issues that we were investigating, was because there were a high number of migrants to the UK in that sample. And for those people, their experience of homelessness was much more structural in orientation. It was about the fact that they couldn't access housing or welfare benefits very often in the UK, rather than it being about more complex issues of personal trauma. So those populations looked extremely different. The indigenous population, in the sense that we use it in the UK, people who are UK citizens, were reported far higher levels of complexity in their experiences than did the migrants. The extended interview, I'd like to go on and say something, spend 5 minutes or so talking about the findings of the extended interview survey. I will skip over this slide because we are a bit short of time and go straight on to the clustering analysis that we did. So in the extended interview stage, we were able to explore people's experiences in far, far more detail. I mean, in the census stage, we asked 14 yes/no questions. In this stage, we did 1 hour-long interviews, and again, we used CHP technology. We asked some of the most sensitive questions using self-completion and so on. So we were able to also ask some very challenging questions and to get into real depth on people's experiences. The idea of the cluster analysis was to see whether there were, again, it sort of relates to some extent some of what Rosanna was saying in her study about typologies and so on of experiences. We were looking to see whether there were sets of experiences that tended to go together within this population of people who were using low threshold services with experience. Were there distinct subgroups within that? And we found indeed, yes, there were. And the cluster analysis came up with this five-way division, which again has had quite a big impact in the UK, because I think the services who work with this kind of extreme end of the homelessness spectrum feel that these clusters kind of make sense to them. The first one we called mainly homelessness, which was about a quarter of the sample, and that was the people who reported the least complex set of experiences. I've said there that there's 5 experiences that people reported. That's out of 28 core experiences of deep exclusion. We asked a whole set of indicators about homelessness, about substance misuse, institutional living and street culture activities. And out of those 28 experiences, people in this group on average reported 5. They were most likely, as I've already suggested, to be migrants and non the sample. That's the least complex group. The next group, which was significantly more complex, we've called homelessness and mental health. And this was a disproportionately female group, as you probably expect from previous research. There was still majority men in it. It was 39% women, and the balance was men. But it was a higher proportion of women were in this subgroup than in the sample as a whole. In the sample as a whole, women were 20% and men were 80%. So I'm speaking through these, I know, but we're out of short of time. The next subgroup we've called homelessness, mental health and victimisation. You could see this cluster, which was a smaller cluster, is almost like a more extreme version of cluster 2. These were people who 100% of whom were willing to report very extreme issues of suicide attempts, self-harming, and 91% had attempted suicide on at least one occasion. 75% had self-harmed. About 3/4 had been a victim of violence. This group was younger than average, and to put it very kind of, perhaps very briefly but crudely, this was the young caregivers group. This is where most of the caregivers in the sample were concentrated in this particular subgroup. There was then a really quite a well-defined cluster 4, which were, to put it very briefly, older male street drinkers who had a very different set of issues from the 2 clusters that I've just been talking about. Things like levels of suicide attempts and so on were much lower, but street drinking, alcohol problems, and engagement in street culture activities like begging were extremely high. Homelessness and hard drugs is cluster 5, and this was in many ways the most extreme cluster. People reported the largest number of experiences. The reportage was very high across all 4 of the domains that we were looking at. So people in this group had generally experienced all of the forms of homelessness. They'd experienced multiple forms of substance misuse. They'd experienced multiple forms of institutional living, and they were heavily involved in street culture activities as well. These were mainly men in their 30s and their 40s. It was a very clearly defined group, and chaotic use of heroin in particular was extremely important within that particular cluster. The final thing I want to talk about in terms of the key findings of the study is based on some sequencing analysis which we did. Probably the thing which we were more interested in than above all else really in doing this study was to try to work out pathways into these extreme forms of homelessness. We wanted to work out what order things happen to people in, and whether that could help us understand people's roots in. So again, a lot like some of what Suzanne is doing with that broader homeless population in Australia. How we did this is all the 28 experiences that we asked about. We asked first of all people, had they experienced it? If they had experienced it, we used what we call shuffle cards. We asked what age they were when they first experienced it, wrote that age on the card, and then used the shuffle cards to basically provide a timeline. We then asked them to confirm that timeline was correct, and we shuffled it if it wasn't. So we have a sequence analysis for all 452 people that we interviewed. And what we found was that the sequence was remarkably consistent, far more than any of us were expecting, and it was actually really quite consistent across all 5 clusters. And the summary is up there. The first phase, which people almost invariably reported in their mid to late teens, was when they became first involved in substance misuse or problems with drugs, alcohol and solvents, around about age 15, 16, 17, and leaving home and care, which was usually around age 17. The next phase, which we have described as the transition phase, the street lifestyles, usually involved people beginning to, the form of homelessness that came up at that stage was sofa surfing. That's when people started to have unstable housing circumstances, but also mental health problems come through very strongly at that point. And with this time we're talking late teens, very early 20s, so age 19, 20, 21. For the minority, and it was a minority who were engaged in street survival sex work, about 10%. Of course, Muslim women, it would be around this age as well. Survival shoplifting also became first emerged at this point, and engagement with the criminal justice system. There was then the next phase we called confirmed street lifestyles, was actually an extremely sort of clear phase where the first experience of sleeping rough, of begging and injecting drug use tends to happen in really quite close succession, closely intersected, and that was around the mid 20s actually, to some extent towards the late 20s. And then after all of that, we had what we call in the UK sort of more official forms of homelessness. And it was at that point, in the late 20s, that people usually first approached hostels, the formal homelessness system for help. And also in the UK, we have a statutory homelessness system whereby local authorities have a duty to rehouse certain priority groups of homeless people. And if people applied to the local authorities homeless, then it tended to be around this phase as well. And this was sort of late 20s into the very early 30s. So I think the thing that was most striking about this sequencing was that how consistent it was, and it was consistent across all 5 clusters. So, for example, the chances of you ever having begged were really quite fundamentally different depending on which cluster you were in. If you were in cluster 4, the chances of you having begged were very high. If you were in cluster 3, actually the chances were much lower. But if you had begged, then you begged at the same point in individual sequence. So across these clusters, although the overall
frequency of experiences varied, the order in which they happened was extremely consistent, and we really weren't expecting that at all. It came as a big surprise to the research team. So just to finish on implications very quickly, I haven't had time to say anything about the childhood trauma points, but it very much reinforces what we've been hearing from Robin already today. The extent to which the people in this group reported very severe family and school problems, and also various forms of trauma and neglect specifically, was extremely high across the sample. We asked quite a lot of questions about that. The clusters of experience, I think, have been taken on board in the UK as helpful in planning services, but obviously on a broad level, not about, it's certainly not a substitute for individual needs assessment, but giving a sense of the kind of issues and concerns that might sometimes go together. The thing that's had the biggest policy and practice impact has been the pathways analysis, and it's been used both in national policy and some of the individual large delivery services have taken on board very much that pathways analysis to help to inform prevention interventions. And in particular, they've taken on board this point that visible homelessness tends to happen very late in people's NEH pathways. At the moment in the UK, we've tended to focus homelessness prevention around local authority and voluntary sector homelessness services. And what our research says is that's too late in the day. It's going to be criminal justice, schools certainly, criminal justice, and hopefully drug and alcohol services that come in contact with people well before housing and homelessness agencies do. So you have to push prevention efforts upstream. But that doesn't for 1 minute undermine the approach to tackling homelessness. You've seen what a ubiquitous experience homelessness was, and we mustn't confuse pathways into an experience with pathways out of it. Just because homelessness isn't where people start, it can giving people the opportunity of stable housing can very often be the indispensable starting point for allowing them a pathway out of that situation. We've made quite a lot of the point about the most extreme forms of NEH being found among men in their 30s and early 40s, because to some extent they're kind of a forgotten group, certainly in the UK homelessness sector, where the highest quality provision tends to be focused on younger people or, to a smaller extent, elderly people, but this sort of group in the middle are, I suppose, a less sympathetic group, and they tend to attract fewer services, but they are the group with most extreme needs. And we've made the point as well that migrants need bespoke services because their needs and their pathways into this form of homelessness is very different from that of UK citizens. And